The subject of today's talk is the painful collapsed or flat foot. And the reason that we don't have a good title for this talk is that there isn't a good definition for the term flat foot or collapsed foot. The subtitle is How did the flat foot get there and what should we do about it? So there are a lot of questions about flat feet. Most of them we don't have answers for. First, what makes a foot flat? Why does it hurt? How do we evaluate it? What are the treatment options? And what are the most common questions patients ask? So these are the questions that patients seem to ask most frequently. Is this genetic? Are there some exercises I can do to prevent the need for surgery? If I do need surgery, how long do I need to be in the hospital? How long do I need to be on crutches? How long do I need to wear a cast? And how long do I need to be off work? So we'll try to answer a little bit of those as we go. Last year I was a resident in 1986. The treatment for adult painful flat foot was lose weight, wear a University of California biomechanics laboratories insole, sit down more often, and quit complaining. And if you didn't have success with those 4 treatment techniques, we do a triple arthrodesis and put you in a cast for a very long time. And in those days we did very little to guarantee that a triple arthrodesis was done in a good position, and it didn't often solve the patient's problems that they presented to you with. So we don't know a lot about it scientifically. We know that it looks flat to someone, and we know that it hurts. But we don't have a good definition. We don't know what causes it to be flat. We don't know what causes pain in a foot that's flat and why some are painful and some are not. We don't know how many types of flat foot there are. We don't know which feet become symptomatic, and we don't really know the best treatment. One thing that's widely accepted, and I think almost everyone will agree, is that flat foot without equinus is usually not a problem. The vast majority of people with flat feet have no medical problems, don't need any treatment, they don't need orthotics, they don't need exercises, they don't need a surgeon. And the best study on the subject is an old one. It's over 50 years old, and during World War II, Harrison Beath in Toronto looked at all the Canadian recruits for World War II. In those days, they used to turn recruits away if they had flat feet, but in the World War II, they weren't turning people away for very many things, and they followed those patients who had previously been turned away, and found that in the absence of a tight heel cord, or in their words, contracture of the triceps suri, a flat foot is within the normal contour of the stable foot and not the result of weakness. So this was the first study that really looked to see if flat foot itself was a problem, and found most of the time it's not. It's only a problem if there's a tight heel cord. So you can ask why a foot gets flat, but the alternative is to ask why a foot's not flat. If you take your hand and push it down on the top of a table, it flattens out completely, and it's an analogous anatomic structure to the foot. So there are things that keep the foot from flattening out in the way the hand does, and those things are bony and ligamentous structures like the plantar fascia and the spring ligament, and some dynamic supports like the pull of the peroneus longus and the tibialis posterior. But those things don't fire during quiet standing. The tibialis posterior does not fire when you're standing with your foot on the ground. It only fires in early heel rise. So the majority of the orthotic management strategies that are designed to compensate for an incompetent posterior tibial tendon really aren't very well thought out. So the critical soft tissues that we know of, at least, are the triceps causing a deformity. So if your calf is tight, it pulls up on the heel and the foot's more likely to collapse. The posterior tibial tendon and the peroneus longus provide dynamic support, and the spring ligament and Lisfranc ligament keep the arch from collapsing in the same way that an igloo is blocked from collapsing by tethering of the underside of the chunks of ice. The tibialis posterior and the peroneus longus plantar flex the first ray. This is a 3-dimensional CT model of a cavus foot with overpull of the first ray. And if you look here where the arrow is, you can see that something is pulling this first metatarsal down beyond where it should be relative to the cuneiform. You should not see a step off at the top of the cuneiform. And if you look at what happens on this little video clip to the peroneus longus muscle, as you plantar flex and dorsiflex the first ray, you can see how much excursion there is in that peroneus longus. It's a relatively powerful plantar flexor of the first ray. And if it pulls, then the arch is much likely to collapse. We don't have a very good definition of what a flat foot is. This is a patient of mine who had very, very flat feet. The right side, which is on your left, had no pain at all. And you can see if you look at arch parameters, the relative width of the heel contact and the midfoot contact would easily classify this as a very flat foot. On the other hand, if you look at the lateral border of the foot along this line, it's not abducted. It's right in the weight-bearing line. This one has no pain. This foot, on the other hand, is very painful. And if you draw those same white lines, you see that the foot is drifting out of the weight-bearing line of the foot. And not unusual for middle-aged flat-footed patients, the patient has substantial girth that contributes to the overly oppressive weight on that hind foot. And this is what the patient looks like when viewed from behind. This is the leg coming down and the heel drifting out. And if you look at imagine the body weight following this line down to the foot, you can see that there's a lot of torque pushing that heel outward. This is that same foot when viewed from above. Again, looking down the tibia, the foot is abducted substantially. And when you look at it from the inside, you can see that there's virtually no arch at all as the foot flattens right out on a piece of glass like the hand would. There are a lot of radiographic definitions of flat foot. This is a recreation of a diagram from Nunley's article in Journal Pediatrics. The number one thing to look for is a line down the axis of the talus that should pass down the axis of the first metatarsal. I think Dr. Hansen told me about 20 years ago that all you really have to look at to determine if a foot is flat is the relationship between the talus and the first metatarsal. And this is an axis that Miri described 40 years ago in the French literature. Another radiographic finding that's important, and what we found is the most sensitive indicator of correction and of collapse, is the talonavicular coverage angle. This is a talus bone drawn in, and this is the navicular. On a flat foot, the navicular drifts laterally and superiorly away from the head of the talus. And you can draw an axis that defines the edge of the articular cartilage of both and an axis plumb to it. And there's an angle in here that defines the talonavicular coverage angle right in this axis here, and it's shown on the side as well. So if you look at a whole lot of flat feet, you'll find that they come in lots of different shapes and sizes. So each of these is a flat foot, and each of them is completely different. So I think it's important not to talk about flat foot as if it's a disease, but talk about the anatomic structures that are abnormal. So on the first foot on your top left corner, there's a sag at the talonavicular joint. The one below it has a perfectly normal talonavicular joint, but a sag at the navicular-cuneiform joint. On the next one at the top right corner, all of the sag is between the first metatarsal and the cuneiform. And on the one in the bottom right corner, there's a gradual sag all along the whole foot with no real standout sag at any one joint. And each of these, clinically, has an abnormal talometatarsal axis. Same if you look at a top view or an AP view of the foot, each one of these is a flat foot, but each one has its abnormal alignment in a different location. So if we come to this side, which you can see a lot better than I can from where you're sitting, there's a gradual erosion of the talonavicular coverage and a pretty big significant naviculo-cuneiform abnormality. On this one, there's an abnormal calcaneal cuboid joint with subluxation here on this side of the foot, as well as uncoverage of the talonavicular coverage angle here. This one on the third is entirely coming from Lisfrank's joint, and this one, the final one, has a gradual change throughout the whole midfoot without a specific spot leading to the flat foot. So again, there isn't a diagnosis, there isn't a term we can use to describe all these feet, and it's best just to look at the anatomic problems that each one causes. So a few pretty smart people have looked at whether we can actually diagnose this based on clinical exam or on radiographic evaluation. So Charlie Saltzman looked at 14 different radiographic parameters and found none of them was really terribly reliable to determine if a foot is flat or not. Cowan took a bunch of clinicians and had them look at feet and say, is this a flat foot or not a flat foot? And the correlation coefficient was only 0.57. So if you take 100 people, they only agree, 100 examinations, only 57 of the times they actually agree with one another. Radiographically, the talonavicular coverage angle is most sensitive. So it's a little worrisome that we don't have a good term to describe it and we don't have good agreement among clinicians to define the problem. So we set out a few years ago to try to make this a little bit clearer by creating computer models of these deformities. And the way this was done by obtaining a simulated weight-bearing CT scan, we created outlines of the bones on two-dimensional images. Then we stacked these two-dimensional images into three-dimensional models and added ligaments and cartilage. And this is one clip taken out of a video clip of the foot weight-bearing. And this is a Flatfoot CT on your upper left. So here's the talus, calcaneus, navicular, cuneiform, and first metatarsal. You can see that in this particular case there's a gap at the cuneiform first metatarsal, and a talo-metatarsal angle drawn down this way would show a clear relationship, a clearly abnormal Meary's angle. A top view shows it again. Now here we're looking at talus in light blue, navicular is in purple, calcaneus is underneath the talus in red, and a line drawn down the axis of the talus doesn't come anywhere near the first metatarsal, showing substantial abduction in this case. And just for comparison, the foot on the right, on your right, is a cavus foot with the same type of CT-generated model, showing the axis this time going all the way to the third metatarsal, the opposite kind of deformity. So the question remains, can we define Flatfoot in a way that makes some sense? So we took some of these 3D models to try to answer that question. We took 40 subjects and placed them into groups that were flat foot, cavus foot, and neutrally aligned foot. We did simulated weight-bearing CT scans on them to create these 3D volume maps of the bones. And for the non-engineers, we let the computer assign an axis by a process called inertial matrices, basically just using the volume of the bone to determine what its longest axis was, a second volume of the bone to determine an axis perpendicular for the second longest axis, and then the third of the three orthogonal axes was assigned by the computer. So we didn't tell it what to do. We just said, find the axes, here are the bones, here are the feet that are flat, here are the feet that are not flat. And then we used a statistical tool called the classification tree analysis, which most orthopedic surgeons know nothing about, including myself. But basically it allows the computer to randomly assign patients into categories based on these inertial matrices that they assign. And to our surprise and delight, 62 of the 64 feet were classified correctly by passive computation. So basically just by saying, here's Meary's angle, assigned by a computer, we're classifying them right. So it sounds like the clinicians are a little bit smarter than we've been giving ourselves credit for, because the computer can almost completely recreate what we've done just by looking at the shapes of the bones. So this is just how this is a fifth metatarsal bone, and this is one that has had this computer-generated orthogonal axis attached. And here's one example of a flat foot with the talus in dark blue and the first metatarsal in gray, showing a drift of the forefoot away from the long axis of the talus. And these are just three examples of a cavus foot. Again, here's the talus bone, and here's the first metatarsal, showing that this right foot is very adducted. Here's a neutral foot showing the axis of the first metatarsal going right along the axis of the talus. And here's a flat foot showing the axis of the talus passing medially to the first metatarsal, just as we would have predicted. So now we know we're not so bad. The Meary's angle actually works, and that the things we thought were important are actually thought to be important by the computer as well. When you work up the patient, it's important to know that a weight-bearing film should be done. Here's a film of a foot and a patient with a flat foot that looks perfectly normal. The talus first metatarsal angle is normal because the patient wasn't really putting his weight on the film. Here's the same patient with a little bit more weight, and here's the same patient with a fully weight-bearing film. So unless these films are done weight-bearing, and unless the CTs are done weight-bearing, we really can't get a good idea of what the problem is. The same applies on a lateral, where the talometatarsal angle goes from completely normal to completely abnormal with weight-bearing. I like to use weight-bearing CTs to help me define these as well. I know that this is not a widely used technique, but it helps us see things that can't be seen by a plain film. So here's a sagittal reconstruction of a relatively bland flat foot. You can see how severely inclined the talus is relative to the first metatarsal, and you can see this very dramatic subluxation of the of the cuneiform metatarsal joint. As well, on the sagittal reconstruction, if you look at the bottom corner, you can see that the sinus tarsi is completely closed down. So the calcaneus is very everted. It's closing down the sinus tarsi. And on the coronal cuts, you can see the true peritalar subluxation that we talked about a little while ago. So here's the talus, here's the middle facet, and you can see that the middle facet of the calcaneus is drifted lateral relative to that of the talus. So this is a peritalar subluxation. This is the same patient with a relatively mild looking x-ray and a relatively mild CT, but still showing about 50% subluxation of the middle facet. So we know that Flatfoot is defined as an abnormal position of the bones, and we know that it's pretty common. About 10 to 30% of adults have Flatfoot as defined by arch parameters. There's some data in the British literature that's not been supported by other documents, but there's a suggestion that if children wear shoes when they're young, they're more likely to develop a Flatfoot than if they go barefoot when they're young. This is the only paper that I know of to come to that conclusion, but it's an interesting idea since there's substantial literature trying to support the use of orthotics in children. I think there's really no foundation for that, for using orthotics in a child with a flat foot. So we talked about the importance of a tight heel cord in assessment, and it's important that the heel cord be assessed with the talonavicular joint in the neutral position. This is a diagram out of Luc Bordelon's book, in which he puts his thumb right at the talonavicular joint to make sure that it's positioned properly, as it's done here, before the exam, to make sure that you're not fooling yourself into thinking the heel cord's not tight. So here's a patient who has the leg straight, the foot almost perpendicular to it, and you could almost convince yourself that this is not a tight heel cord. But if you examine the patient, you see a lot of motion. Let me just run that again. You can see that it seems to dorsiflex completely into a neutral position, but a lot of that change is coming through the midfoot. Now if you take that same patient and lock the talonavicular joint with a thumb, thereby restoring the nice arch that you can see here, and then try to examine the same exam, here's with the knee bent, and here's with the knee straight and attempted dorsiflexion, you can see that there's about a fixed 20 degrees of equinus, even though the foot looked completely neutral without locking that joint. I'm going to run that clip again. You can see when the knee is bent, it comes up, but when the knee is straight, you're fixed in 20 degrees of equinus, indicating that all of that tightness is in the gastrocnemius, not in the triceps. So it's nice if it's all in the gastroc, because then you can release the gastroc only and not have to worry about casting in the postoperative period. When Steve Pinney was here as a fellow, he took this little toy we developed called the equinometer to measure equinus in a large number of patients who had tight heel cords. And he measured them before release of the gastroc and measured them after the release of the gastroc. And to no one's great surprise, found out that there's nearly a perfect correlation between the amount of dorsiflexion you can obtain with the knee bent preoperatively and the amount of dorsiflexion you can obtain postoperatively after a gastroc release with the knee straight. So essentially, the equinometer can predict how much correction you can get. So if you measure the amount of dorsiflexion they have and it doesn't come up enough with the knee bent, then you probably need to do a tendo-Achilles lengthening rather than a gastrocnemius release. So interestingly, there's been a lot of talk lately about arthritis of the ankle, and we found accidentally in the review of one of our fellows a couple years ago, in looking at 435 patients with ankle arthritis, if you eliminate the patients who've had a fracture of the joint, eliminate the patients who've had an inflammatory arthritis, and just look at the patients who are so-called osteoarthritis of the ankle, you found that almost all of those patients had either a cavus or a flat foot. So not surprisingly from mechanically oriented people, but if the foot is tilted, the ankle wears out. So there's one more reason to think about treating this problem before people get to the end-stage arthritis position. So about 10 years ago, we tried to figure out, is an acquired flat foot acquired because the bones change shape or because the position of the bones change shape? It's kind of a horse and carriage or a chicken and egg phenomenon. What causes it to be flat? So to try to answer that, we again looked at some three-dimensional models. So here is a calcaneus, here's a talus CT scan, here's the middle facet, as you can see clearly subluxed. So you can draw a line along the middle facet of the calcaneus, draw a line along the middle facet of the talus, and you can abstract that line alone into its own field. And then you can stack these lines into a software product that'll create a surface map. And we compared a group of patients with symptomatic flat feet to a group of patients age-matched without symptomatic flat feet, and this is the map that we created. So in blue is the talus surface, middle facet and anterior facet on this side, and in red is the calcaneus and posterior facet. And so here's posterior facet, calcaneus in blue and talus in red. Here's middle and anterior facet, same color scheme, of a normal patient with a normal foot. Here's that same surface map of a patient with flat foot disease, and you can see that instead of the talus being on top of the calcaneus has drifted posteriorly and laterally relative to the talus. So this is true subluxation of the subtalar joint. So the answer must be that there's subluxation causing the problem rather than joint morphology. But just to make sure, we also looked at the opposite problem, and we're not the only ones. Deland and Dial looked at radiographs of flat feet in non-symptomatic patients and compared them to patients who are symptomatic and found that there was really no difference in the radiographic parameters. So there's some other issue other than radiographic parameters in bone shape. So we took it a step farther and looked at the three-dimensional shape of the bone by using the same surface map technology and compared the shape of some of the hindfoot bones. And we found that, in fact, there is a difference between painful flatfoot surface morphology in that the talus is significantly wider and the body is less high. But then when we compared non-symptomatic talus flat feet to symptomatic talus flat feet, we found that there was no difference. So there's some shape abnormality that predisposes a person to have a painful flat foot. But some people go on to painful flat foot and some people don't. So we know that it's a combination of abnormal shape and abnormal position, but there are some other mysterious factors that we can't calculate quite as well. Why does it hurt? We know that some of them hurt because the posterior tibial tendon is inflamed, some other issues. If you take these same three-dimensional CAT scans or weight-bearing CAT scans and you look, you see not only abnormal arthritic conditions, but also abnormal impingement. So here's the calcaneus, talus, fibula, and tibia. And you can see that the calcaneus is completely eroding into the fibula. I don't know where the peroneal tendons are. They should be in that space. You can also see that the sinus tarsi is completely collapsed. There's actually arthritic conditions where there shouldn't be a joint in the first place. So here's a three-dimensional model of a flat foot. This is on the top, talus. We're looking at the front of the talus and the front of the calcaneus. And here's looking from behind. Again, at talus, we've made the calcaneus see-through, so you can see that the entire border of the foot is moving laterally. As the calcaneus drifts laterally, the cuboid follows it, and the whole forefoot does as well. And you can see this is a CT scan, a weight-bearing CT scan of a patient with symptomatic flat foot. You can see that the calcaneus is eroding into the fibula. The talus is no longer covered, and the talar head is plantar flexing. If you look at that same patient after lateral column lengthening, the space is recreated beneath the fibula. You can still see the eroded area. And the talus is now supported by the sustentaculum tali, and the lateral border of the foot is completely straight again. So it's analogous to these plastic models. You can see as the medial part of the arch collapses, from normal to collapse, there's a gapping of all the joints. And as you look to the back, the calcaneus goes from this normal position to this abducted position. A little video clip is surprisingly similar to what we see in the real world. So as you push down on this plastic articulated model, it opens up in the same way that the CT scan we just showed did. And if you look at that same articulated model from behind on the lower clip, you see how the calcaneus translates laterally and into the fibula. And if you compare that to a weight-bearing CT model, it's very, very close. It's a very close simulation. So this seems to be simply a matter of gliding along the normal axis of the joints. So what does this all mean? It means that there are a lot of things that lead to painful flat foot. The shape of the bones is a problem, the spacing of the bones is a problem, and the treatment really needs to be geared toward whatever that problem is that has resulted in this end-stage flat foot. There's no single treatment that works. So the treatment options are bracing, soft tissue balancing, osteotomy of the bone, and arthrodesis of the bone. In terms of non-surgical treatments, I think the simplest is the University of California biomechanics type orthosis. This orthosis captures the heel, it inverts it slightly, that allows the midfoot joints to lock, and it corrects some of that subtalar dislocation. It also gets the calcaneus more in line with the underside of the talus. It's not a very good long-term solution, but it's a good solution for patients who have medical comorbidities or some reason why surgical intervention is not good. If you have someone with a more severe problem who also is a not surgical candidate, an Arizona brace, which is a custom leather lace-up brace, is an alternative. It's essentially like wearing a very high boot or a custom-made cast for the rest of your life, but for some patients it's an adequate therapy. The surgical treatment's a little bit more complicated. The only thing you can say almost for certain is that either the gastrocnemius or the triceps need to be released. The rest of the problems have to be individualized to whatever is found. So flexor digitorum longus is the most common soft tissue procedure performed. That can be put into the cuneiform as shown in this diagram. If you use this approach, it does allow a little bit of undersurface support for the talonavicular and navicular cuneiform joints. It can also be weaved directly into the posterior tibial tendon as it's shown here, with the ankle up at this end and the toes down at this end of your screen, if the posterior tibial tendon is sufficiently healthy. A medial column fusion or arthrodesis is good for those patients who have a midfoot sag with very limited forefoot abduction and only small amount of hindfoot valgus. Can be a corrective arthrodesis through any of the midfoot joints. There isn't a lot of outcome information on this study, and it's been around since at least 1931. So this is a poor quality diagram out of an article from that original article, and you can see that a trough is just made in the medial part of the foot, and the bone graft was just placed into this position. This was long before the days of rigid internal fixation. This is a great quote from Miller's article in 1927. There can be no dogmatic classification of so-called flatfoot. Treatment should be geared toward its discomfort, ugliness, and the end result that you expect. And practically always the heel cord is pathologically shortened. So that hasn't changed much, but the technique has changed a lot. He just used a strip of bone or a piece of tibia. Now we tend to do something a little bit more thoughtful in that we can hold the position of the bones with internal fixation. So this is a perfect candidate patient for a Miller procedure. You can see that there's a sag at the metatarsal cuneiform joint in this area, and the Meary's angle is abnormal, but there's not a huge amount of closing down of the sinus tarsi, just a moderate amount of closure, and only a small amount of abduction. And if you look at the post-op film after the Miller procedure, you see that the talometatarsal angle is completely normalized, and the sinus tarsi has opened up with no hindfoot procedure at all. So this is a pretty good operation for mild hindfoot valgus. It's just not very good for dramatic hindfoot valgus. And you look at the AP view, you see that the talonavicular coverage angle is back to normal. The talus and the first metatarsal line up exactly as we'd hoped that they would. Medial column arthrodesis can be combined with other procedures, such as this patient with a much more dramatic talonavicular subluxation. In this case, a lateral column lengthening combined with a medial column stabilization brings about all the corrected change that's needed. In this case, the lateral column, the Miller procedure is done here, and the lateral column lengthening is done here on the calcaneal side, and that corrects the much more severely abducted foot. Calcaneal osteotomy has gotten a lot of press. It's something that was described a long time ago by Gleich. Koutsaganis had the most recent significant article on the subject, and even that is 30 years old. But basically with this operation, you cut the heel and you move it over until it's underneath the axis of the talus, thereby taking away the abnormal torques going on in the hindfoot. And his review demonstrated, one, it doesn't work without lengthening the heel cord, and two, that it's not enough for severe deformity. Now, he didn't obviously have CT scans in those days, so he couldn't tell if these joints were subluxed, but even he was able to observe that if you can't correct the alignment, then the operation doesn't work. So this operation works for patients with mild disease, as in this case. You can't really see the subtalar joint, it's subluxed a moderate amount. But postoperatively, after doing the medial column stabilization and after moving the heel over, the sinus tarsi opens up without a lateral column lengthening. You can see now a good lateral of the ankle and a good lateral of the subtalar joint. So lateral column lengthening is an alternative to triple arthrodesis for the patients who are more severe than either of these groups. It can be done through the anterior process or the calcaneal cuboid joint. It's done, as you know, by taking a large block of tricortical bone and cutting the calcaneus and fitting it in. This is a patient that Dr. Hansen did when I was a fellow back in 1987. This was a young person with a very flat foot. And if you look at this person's CT scan, you can see that even though it's a young person in her teens, he already has invasion of the calcaneus into the underside of the fibula. So this is not going to be something that's going to get better on its own by any non-operative means. You can see that the calcaneus is already impinging, and after the correction with the lateral column lengthening, the similar CT scan shows that talus now completely on top of the calcaneus and that fibular space completely opened up so that there's no longer any impingement. That's just a tendon Achilles lengthening and a lateral column lengthening through the body. As I said, this can be done through the calcaneus or through the calcaneal cuboid joint. It's all a matter of bias and what the patient has. For example, if the patient is like this one, here's a CT scan in the transverse plane showing substantial erosion and subluxation of the calcaneal cuboid joint. It makes sense to do that lateral column lengthening through the calcaneal cuboid joint rather than lengthening through the calcaneus and putting more pressure on an already arthritic joint. And this is what that arthritic joint looks like. So here's the graft. This whole area in here is graft, about 1.5 centimeters long. You can see that here's the pre-op with talonavicular joint completely uncovered, and after just this 1 centimeter block, the talonavicular joint has restored its almost normal position. Similarly, on the lateral view, where there's a big sag in the talonavicular joint here, it's completely restored a normal talo-first metatarsal angle on the post-op. And clinically, the foot goes from a pancake-like appearance on your left to a relatively normal arch on your right immediately after the surgery. So here's just a little clip to show how the lateral column lengthening works. This was put together by one of our chief residents a year ago. This is a cadaver foot in which we have created an anterior process osteotomy here. And I'll just clip it and kind of talk my way through it as it goes. There's the calcaneus, the cuboid, the navicular, the talus, and the tibia and the fibula. Looking at it from behind and from the medial side. Now we're going to fix the talus to the calcaneus to see what movements Chopard's joint does with the lateral column lengthening. So now we're inserting a red block of bone. You can see that the navicular moves up and over on the talus. And for frame of reference here, we fix the talus. The tibia moves and the hind foot moves all around the talus. So really the talus would move from a plantar flexion to a dorsiflex position, but we fix the talus. Now we've unfixed the subtalar joint, we're going to do the same thing. Taking it back out, you can see that there's a lot more motion in the subtalar joint, but most of the motion is through the midfoot. There's a dramatic movement of the talonavicular joint. And finally, we're going to look at it from the top and take away the tibia. Look at how the whole forefoot pivots around the talonavicular joint. So this is a very powerful surgical tool for correcting all three planes of the deformity. And this is a patient who had a lateral column lengthening and went from a very, very pancake-like foot to a relatively normal arch. And here's another patient who shows this used to be his good foot, and this was his bad foot. And this is nearly completely restored with just a tendo Achilles lengthening and lateral column lengthening and nothing else. And this is just a 13-year-old who happens to be 6'6" and is already getting some interest from NBA scouts. Finally, the last osteotomy that can be done before going to a triple arthrodesis is combining the two, the lateral column and the glyc osteotomy. These are some pictures Art Manoli sent me as this is his primary procedure. You can see that this is also a very powerful tool. It's a little bit of a tendency to overcorrect the hindfoot pitch, but is otherwise a very effective tool as well. And this is a patient who's had a correction on this side and not had a correction on that side. You can see that the motion is nearly identical even after this fairly substantial osteotomy. So these operations don't interfere with joint motion at all. Finally, if the patient is just too flat for anything, a triple arthrodesis remains an option. This also may be an option for the so-called tight floor flat foot. So here's a patient laying on the table. You can see the patella is indicated by this red arrow pointing straight up at the ceiling, and the foot's rotated out about 45 degrees. This is quite dramatic subluxation, not likely to really be corrected by any of the lesser procedures. If you look at this patient's radiographs, you can see that talometatarsal angle doesn't even hit the navicular, never mind the first metatarsal. This is a completely subluxed foot. And in the lateral view, you can see that the foot is quite literally falling off the end of the talus. So for these patients, I think the only good opportunity is to get that sinus tarsi open back up and fuse the three triple joints, or do a triple arthrodesis. This is a very effective tool. You can see from the clinical photos that the foot is now in line with the leg, if I get my arrow to work. So here's the patella. The foot's now completely aligned with it, as opposed to this 45-degree angle it was making preoperatively. So the surgical options include soft tissue procedures, medial column procedures, lateral column procedures, osteotomy, and fusion. And there's a lot we still don't know, but it seems that there's a shape of a foot that's common that predicates these patients to have pain. The flat foot's not a disease. It's some kind of common endpoint for a variety of subluxations and soft tissue problems. A tight heel cord is almost certainly part of the complex in the vast majority, and both subluxation of the joints and intrinsic shapes of the bones contribute. Treatment really should include balancing the soft tissues and restoring the normal relationships of the bones. So in answer to the patient's questions, is this genetic? There seems to be a little bit more of a tendency to occur in families, but no one has really identified a genetic link. Are there exercises I can do to prevent surgery? The only exercise I tell people to do is to stretch the heel cord, and the only data that shows that it works is very, very limited data. And probably by the time adults get to you with this flat foot deformity, the exercises aren't going to help them all that much. If they need to have surgery, they're going to be in the hospital a variable amount of time, from 1 to 3 nights, based on how many of these procedures they need. They need to be on crutches 6 to 10 weeks. They need to wear a cast for between 2 weeks and 12 weeks, depending on the procedure done. And they need to be off work between 2 days and 2 weeks, depending on how much they like their work and how much they have to be on their feet. So thank you very much for your attention. I'd be happy to answer any questions. Dr. Hansen.
I occasionally get fooled by the fact that the patient has a congenital coalition under their flat foot. I'd be interested in what are the signs that you have that make you suspect that, how you evaluate for it, and how it changes your treatment.
So that's a great question, and obviously if you can be fooled by it, a lot of other people can be fooled more easily. The one thing that I do is do a weight-bearing CT scan on every patient who I'm considering surgical intervention. And as you know, a tarsal coalition is much easier to pick up on CT scan, but still on clinical exam, you're going to maybe, if you're lucky, notice that there's limited subtalar motion and beaking of the talonavicular joint. I guess I would turn the question around and ask you, what do you do if you find out that there is tarsal coalition? And there, as you know, there was a recent forum on the AOFAS website asking that exact question. I'd be curious to have your thoughts on what the best approach is.
Well, of course, by definition, the coalition means the talus and the calcaneus are fixed in their sometimes abnormal position. So my feeling is you just have to remove the coalition. And I usually go between the posterior tibial tendon and the flexor hallucis on the medial side, being careful of, of course, the neurovascular bundle, and remove it, and then go through the same process that you've already described.
I think that's good. And you notice that when I showed the video clip of the cadaver foot with the screws in it, that we first fixed the subtalar joint before doing the lateral column lengthening. And one reason we did that is because we had a patient at that time that had a tarsal coalition and needed the lateral column lengthening. And that's exactly what we did. We excised the tarsal coalition, went on and corrected the foot as if it weren't there in the first place. But it certainly does make things a lot more complicated.
Dr. Sangeorzan, patients often ask about return to avocational activities, everything from treadmill, exercise bike, to skiing and running and other activities. I was just wondering what you tell patients in terms of correcting their symptomatic flat foot.
So that's a great question. A lot of the patients could use the exercise. A large percentage of these patients are overweight and sedentary because they've been restricting their activities for some time. Typically the symptoms occur a year or so before they get to us for surgery. So we do want to get them back to as an active a lifestyle as possible. And with all of these procedures, up to the triple arthrodesis, we don't impair any function of the foot. We leave all the major functions of the foot intact so that they can go back to skiing, tennis, hiking, whatever they want to do. But it is a big operation, and I tell them up front that it takes longer to recover from this type of surgery than it does from heart surgery. It'll take them 4 months until they're back into a regular shoe, doing normal activities of daily living, and then probably up to 6 months before they can start doing recreational activities. And for some patients, it takes up to a year before they can go back to running and high-end activities.
What do you tell parents that ask you when they should bring in their children to be evaluated for treatment?
It's a very good question. The question is, what do you tell parents whose children have flat feet? And part of it depends on why the question is asked. The old literature, at least as old when I was a resident in the mid to late 80s, indicated that flat feet in children is not a problem and could easily be ignored. But I think if the children are complaining of discomfort, that's a very different category of patients who just have flat feet. As you know from Staley's article, all children have flat feet when they're young. It's only the patients who get up to be around 8 years to 12 years of age who start complaining of the same type of flat foot problems that adults have. So I'd say as early as 6 to 8 years old, if the child says they hurt, they should be evaluated. If they're just flat and the patient's running and keeping up with his peers, I wouldn't worry about it during the childhood years.
Dr. Sangeorzan, in patients who have bilateral disease, but one side is more symptomatic than the other, is there anything that can be done surgically to prevent the progression of the disease on the other side?
So that also is a very good question. Patients ask that frequently, and the best thing I tell them is, as Dr. Hansen taught me when I was a fellow here, that the tight gastroc is the root of all evil when it comes to the foot. So if the other limb that is not symptomatic has a tight heel cord, then I would encourage them to do stretching exercises, and if there's any question of symptoms beginning, then I would feel very comfortable recommending a release of the gastrocnemius or something to loosen up the triceps or the Achilles tendon on the other side. In terms of preventative treatment surgical strategies for bigger operations, I'm really not likely to recommend a bigger operation than just a heel cord lengthening or gastrocnemius unless the foot hurts. Okay, thank you very much for your attention.